early onset eclampsia, all these conditions, if you really investigate, you may find them. And we have lots and lots of these cases which we have managed successfully. I'm sure you will also be able to do that. So going to the topic further, all of you know that we always say that pregnancy is a hypercoagulable stage, but there is a paradox here. Pregnancy definitely poses a particularly complex hemostatic challenge here. On one hand, the blood has to remain in a fluid state because it has to maintain the uteroplacental and the fetoplacental circulation. On the other hand, it has to protect the woman from the excessive blood loss at delivery. So normal pregnancy physiology is actually increased clotting potential, decreased anticoagulation, and decreased fibrinolysis. So the thrombotic potential of this pregnancy is actually exacerbated by the vena cava compression by the gravid uterus. And there is a stasis in lower extremities as well as in the pelvic vessels. This is further enhanced by the hormonal effect on the veins by increasing the venous capacitance, and of course the insulin resistance and hyperlipidemia will add to the risk. So friends, pregnancy per se is a hypercoagulable state, and if the woman has thrombophilia on top of that, it will further worsen the situation. So let us see what are the common thrombophilias we encounter during pregnancy. The most commonly we encounter the acquired thrombophilia, that is the APLA, what we fondly call it as antiphospholipid antibody syndrome. And the inherited thrombophilias are factor V, prothrombin G2021-0A mutation, protein C and protein S deficiency, and antithrombin deficiency. This busy slide just tells you what is genetic background behind and what is the prevalence in clinical practice. So factor V lesion and prothrombin mutation, it shows guanine to adenine substitution, and the incidence is quite significant, 1 to 3% in general population. Protein C deficiency, protein S deficiency, and antithrombin deficiency, they are because of the mutations leading to either quantitative or qualitative deficiency, and the incidence is quite low, 0.2 to 0.3%. Now, how do we classify or diagnose this antiphospholipid antibody syndrome, or what we call it as antiphospholipid syndrome? So you have to have, according to this revised Sapporo classification, we have to have one clinical and one laboratory criteria for the diagnosis. So what are the clinical criteria? Evidence of thrombosis, maybe one or more documented evidence or episodes of arterial, venous, or small vessel thrombosis, and of course the pregnancy morbidity, which we take it as either the recurrent pregnancy loss of pregnancy less than 10 weeks, that is of a morphologically normal fetus, or maybe more than one unexplained fetal death, that is more than 10 weeks duration, and that too of a morphologically normal fetus. The preterm birth, that is preterm delivery of less than 34 weeks, which is because of the severe preeclampsia or placental insufficiency. Of course, to add to this, we should have the laboratory criteria to be fulfilled. So anticardiolipid antibody, lupus anticoagulant, and anti-beta-2 glycoprotein. These are the three parameters or components which we need for the diagnosis of antiphospholipid antibody syndrome. Let us see what ESHRE says about this. So if you have a woman who has history of recurrent pregnancy loss and you find that she has hereditary thrombophilia, so ESHRE says that we suggest not to use antithrombotic prophylaxis for this woman unless it is in context with the research of venous thromboembolism. But I'm sure as a clinician, you would not like to experiment on your patient who has already had recurrent pregnancy loss, and she definitely has hereditary thrombophilia. So for women who fulfill the laboratory criteria of antiphospholipid antibody syndrome, definitely if she has a history of recurrent pregnancy loss, we suggest low dose aspirin, that is 75 to 100 milligram, peri-conceptional, that is even before conception, and the low molecular weight heparin or unfractionated heparin right from the diagnosis of pregnancy. So Lupus anticoagulant presents the strongest association with thrombosis, and the estimated risk of venous thromboembolism in this condition is almost 15.8%. There are situations where you can have catastrophic presentation, what we label it as catastrophic APS, where you have multiple thrombosis, multiple thromboembolism, and multi-organ failure that can also present during pregnancy and puerperium. This is a table showing you the association between the hereditary thrombophilia and the adverse pregnancy outcome, which may be early pregnancy loss, the recurrent pregnancy loss, second trimester loss, the late trimester or late pregnancy loss, maybe preeclampsia, placenta abruption, FGR, and of course, not to forget the venous thromboembolism. So how do we analyze here? Factor V Leiden and prothrombin mutation, that is actually, these are the two conditions where all the adverse pregnancy outcomes are observed, whereas protein Cs deficiency and antithrombin deficiency, they have lesser chance for having this adverse outcome. Definitely, the chances of venous thromboembolism are there for all of these thrombophilias. So the risk of venous thromboembolism with different inherited thrombophilias. As it is, we know that pregnancy and puerperium, these are the hypercoagulable stage. And definitely these women are 4 to 5-fold, they have higher risk for thromboembolism as compared to the non-pregnant women. Inherited thrombophilias, they are associated with increased risk of venous thromboembolism. In fact, this marks the detection of these mutations a logical target for prevention of the morbidity as well as mortality, which is associated during the peripartum period. Now, to whom this thrombosis develops, what are the risk factors, and how do you score them? So the risk factors can be pre-existing, as we have already said, the various kinds of thrombophilias. You can have certain obstetric factors, and you may have certain transient factors which come into action at that particular time. So if you have the previous episode of venous thromboembolism, and that is not following any surgery, just all of a sudden there is a history of venous thromboembolism which is not related to any surgery, this is very high risk. We score it as 4. If there is following the surgery, there is an episode of venous thromboembolism, we score it as 3. Of course, there are certain known high-risk thrombophilias and the medical comorbidities like cardiac disease, malignancy, certain inflammatory diseases or conditions like inflammatory bowel disease, the polyarthropathy, and diabetes mellitus, nephrotic syndrome, etc. All of these we score it as 3. Of course, the lesser risk of thrombophilias, or we call it as low risk thrombophilias, they can be familial ones. There can be, the age about 35 years, obesity, parity more than 3 years, and of course, smoking and gross varicosities, which we score it as 1. So coming to the obstetric risk factors, having hypertensive disorders or preeclampsia during current pregnancy. All of you know that IVF pregnancy is always a high-risk pregnancy, multifetal gestation. It may be the elective cesarean section, maybe the prolonged labor and operative interventions in the form of mid-cavity or rotational forceps. It may be the postpartum hemorrhage or the preterm birth, and maybe the stillbirth during current pregnancy. All of these, they are scored as 1. Only cesarean section, which is done as an emergency, is scored as 2. Coming to the transient factors, there are certain transient factors like OHSS, ovarian hyperstimulation syndrome during first trimester, it is scored as 4. And any surgical procedure during pregnancy or after delivery, apart from the episiotomy, suppose the patient needs hospitalization again or rehospitalization, then it is scored as 3. And current systemic infection or immobilization, dehydration, all of these, they are scored as 1. So we have diagnosed that the patient has thrombophilia. We have categorized her whether she belongs to high risk, intermediate risk, or low risk according to the scoring system. So if the patient has total score of more than 4 antenatally, then we have to consider for thromboprophylaxis right from the first trimester. If the score is 3 antenatally, we have to consider for thromboprophylaxis from 28 weeks onwards. And if the score is 2 or more, then postnatally, that is even after delivery it persists, then consider for thromboprophylaxis to be continued for 10 days postpartum. If prolonged admission of more than 3 days or readmission, as we have talked about, she will again need the thromboprophylaxis during puerperium. And for patients with an identified risk of bleeding, you have to be really very cautious. On one hand, you have to see that she doesn't land up into thromboembolism. On the other hand, you have to monitor that she doesn't land up into excessive bleeding. So you have to really balance these, and this can be done with the help of a experts and experienced hematologists. So what are the agents which we need to use or we use commonly? First and foremost, the most commonly used nowadays is the low molecular weight heparin, unfractionated heparin, warfarin, the danaphyrid and fondaparinux. They are reserved for women who are, they're not tolerant to any kind of heparin for that matter. Dextran should not be used because of the problems associated of anaphylactic reaction. And you have the oral thrombin and phenol inhibitors. So which agent should be preferred? Of course, I'm sure the answer is unanimously low molecular weight heparin, unless you have some problems or some specific indications for the unfractionated heparin. Low molecular weight heparin, these are the agents of choice for antenatal as well as postnatal thromboprophylaxis. The dose is definitely weight-based, so there is no question of overdosaging or any side effects. So this weight can be the weight at booking or maybe the most recent weight when you have started the low molecular weight heparin. If the woman has now the patient who is on low molecular weight heparin does not need to be monitored for platelet count or even the factor anti-10A, because this doesn't have any effect on this, unless this lady has sometime earlier received the unfractionated heparin. So if the woman has renal impairment or maybe she's at risk of bleeding as well, bleeding disorders, then of course we have to really reduce the dosage. Otherwise, what we calculate according to the weight, either for prophylaxis or therapeutic, should remain the same unless she has the renal impairment. So definitely low molecular weight heparin is also safe during breastfeeding. These are the suggested doses for the low molecular weight heparin for the antenatal as well as postnatal use. All of you know, I'm sure enoxaparin is very familiar to all of you, though this chart is showing dalteparin and tinzaparin. But as we use enoxaparin, I'll be talking about enoxaparin only, the dosaging. If the woman weighs less than 50 kg, the dose 20 milligram per day should suffice as prophylaxis. 50 to 90 kg, 40 milligram daily should suffice. And 91 to 130 kg, 60 milligram per day should suffice. I don't think we need to know for the weight more than 130 kg. I hope nobody gets such a obese woman for her management along with thrombophilia. So coming to unfractionated heparin, in women who are really very high risk of thrombosis, actually we need to stop low molecular weight heparin, as all of you know, at least a day prior, or maybe you have to skip it the same day's dose. But there are women who are at very high risk of thrombosis for whom you cannot even afford to stop the thrombosis prophylaxis even for few hours. And these are the women who, for whom actually you may switch them over to unfractionated heparin. There is increased risk of hemorrhage, as well as, you have certain limitations for regional anesthesia if you're using low molecular weight heparin. So unfractionated heparin can be the choice in such women. So if unfractionated heparin is used after cesarean section, then the platelet count has to be monitored every third day, that is right from 4 to 14th day, or maybe until the heparin is stopped. So because it leads to thrombocytopenia, all of you are well aware of this. There are certain women who actually require long-term anticoagulation, and these are the women who are, they're actually having the mechanical heart valves. So when they are on long-term anticoagulation on warfarin, When they conceive, we switch them over to low molecular weight heparin. So women receiving long-term anticoagulation with warfarin, when they are converted to low molecular weight heparin, again we can shift them back to warfarin postpartum, because the risk of hemorrhage is also reduced after 5 to 7 days, and for her it is quite convenient and cost effective as well. Warfarin, as all of you know, that it is safe during breastfeeding. So postnatally, we can once again shift her to warfarin. So what is the role of these anti-embolism stockings? These are very, very useful devices. These are the pneumatic compression devices, but provided you are using the right size, appropriate size anti-embolism stockings. And the women who are actually hospitalized for some treatment and they are at risk of thrombosis, for whom low molecular weight heparin is either contraindicated or not suitable for these women. In such cases, anti-embolism stockings, when used, as I already said, appropriate size with gradual compression of 14 to 15 millimeter of mercury may be helpful. Some women who are already on low molecular weight heparin, but they are at a very high risk of thrombosis. Maybe they are hospitalized, they are operated, they are not ambulatory. So they are having the score of more than 4 as risk factors antenatally, or maybe this women with thrombophilia, they are traveling for a long distance, maybe 4 to 6 hours or so. So additionally, you may need to provide them anti-embolism stockings, which may be helpful. So for antenatal, this is just a algorithm I'm trying to project here, that we have categorized these women as high risk, intermediate risk, and low risk. So for high risk, you have to start the thromboprophylaxis right from early pregnancy and continue throughout the pregnancy. For the intermediate risk, of course, you may start it after 28 weeks. Here also, this is the list of risk factors, as we have already talked: obesity, age more than 35, parity more than 3, smoker, gross varicosities, and the pregnancy-related complications as well. So here, if the risk factors are 4 or more, then of course you have to start the thromboprophylaxis right from early pregnancy. And if they are 3 or more, then you have to start the thromboprophylaxis from 28 weeks onwards. Postnatally, if the risk factors are less than 3, then only ambulation and avoidance of dehydration should suffice. So this is what the chart is showing, where you want to intervene for some procedures or anesthesia. So whether to stop and when to stop the anticoagulant. So definitely these are the SOGC guidelines, and also it is taken from Journal of Obsgyny 2014. So these are the guidelines which talk about the type of heparin, the dosage, whether it is prophylactic or therapeutic, whether it is unfractionated heparin or low molecular weight heparin. It is different for different type of the heparin. Also, there is a time limit where you have to, when do you stop the anticoagulation, and when do you remove the neuraxial catheter. So for unfractionated heparin, for prophylactic doses, you may not wait for any. You can immediately go ahead with the anesthesia. Also, for therapeutic, you may have to wait for another 4 hours, or maybe just when you do the investigation, if it is normal. Low molecular weight heparin, you have to wait for 10 to 12 hours for prophylactic dose, and more than 24 hours for a therapeutic dose. So this is how it has been stated. When APTT is normal for the therapeutic dose. Low molecular weight heparin is for low molecular weight, as we have already said, it is not safe to remove before 12 hours for a prophylactic, and after 24 hours for therapeutic doses. So this is how it has been stated. When do you start the anticoagulation or the thromboprophylaxis again? So for unfractionated heparin, it is 1 to 8 hours, whether it is prophylactic or therapeutic. And for low molecular weight heparin, 6 to 8 hours after initiation of the anesthesia, more than 24 hours if bleeding during the block or anesthesia, whatever prick you are giving. Definitely for therapeutic dosage, more than 24 hours, we have to wait and see that there is no evidence of bleeding, and then only we have to remove the Neuraxial catheter. What about thromboprophylaxis during labor? So when to stop the low molecular weight heparin or unfractionated heparin? This is what I'm just trying to summarize here. Wherever there is just a little spotting or any indication for onset of labor, the thromboprophylaxis should be stopped. When you have the elective cesarean section, that day's dose of the anticoagulant should be stopped. The regional anesthesia should be avoided for at least 12 hours for a prophylactic dose and 24 hours for the therapeutic dose of low molecular weight heparin. And it should be the removal of the catheter should be withheld for at least 6 to 8 hours after the anticoagulation. So first, thromboprophylaxis dose should be given after delivery when there is no fear of bleeding. So that is usually after 3 days. According to, but here there is a little difference of opinion. Here we are saying that the unfractionated heparin is to be stopped 12 hours prior if the dose is more than 7,500, whereas the SOGC guidelines say that for prophylactic dose that is up to 10,000, there's no need to stop the anticoagulant, or there's no need to wait for the to delay the procedure. So how do you go ahead with the thromboprophylaxis during labor in women with risk of bleedings? There are certain women who are at risk of maybe abruptio placentae, or maybe they are having a bleeding tendency, coagulopathy. So here, definitely, you have to look for some other measures like anti-embolism stockings, foot impulse devices, or intermittent pneumatic compression devices. And of course, here comes to your rescue rather, unfractionated heparin, which also can be used. So to sum up, the high risk woman, you have to continue the thromboprophylaxis for at least 6 weeks postnatal or postpartum. For the intermediate risk, we have to continue the thromboprophylaxis or anticoagulation up to 10 days postnatally. Of course, from this list, if the woman has 2 or more risk factors, again, in that case also you have to continue the thromboprophylaxis for 10 days postpartum. And if the risk factors are 2 or less, then definitely early mobilization and maintenance of hydration should be all that should suffice. Patients, suppose who are on anticoagulants or who are on thromboprophylaxis on low molecular weight heparin or unfractionated heparin, suppose what instructions we are supposed to give them, that yes, you are supposed to continue this, but around the expected date or around the period of intervention, maybe you have to stop it a day or 2 prior. But suppose this patient lands up into emergency and without stopping the drug, or maybe even that day's dosage she has already received, this can present to you as emergency. And maybe to protect, especially for low molecular weight heparin, I don't think for a prophylactic dosage we have till now faced any such complications. What we experience is only the mild capillary oozing and nothing more than that. But yes, definitely for therapeutic dosage or unfractionated heparin, you may have the excessive bleeding during a post-operative period also. So patients who are receiving the anticoagulants, they are at a higher risk of PPH, and such patients you may need to go for protamine sulfate, which is the antagonist for this. So you may have to go for this, for which you have to take help of the physician or intensivist. Only partial neutralization of low molecular weight can be done here. Vitamin K takes at least 12 hours for its correction of the clotting factors. So you may have to keep all the blood and blood components, especially the fresh frozen plasma, ready. So to sum up, pregnancy represents a physiological state where you have hypercoagulability. On top of this, if the woman has thrombophilia, may be acquired or the inherited, And this woman is, of course, at a higher risk for development of various complications, especially the adverse pregnancy outcome, as well as venous thromboembolism, which can be the most common cause of direct maternal mortality. And the most convenient drug for prophylaxis, which we have been using very safely, I'm sure all of you are well versed with this, the low molecular weight heparin. Oral anticoagulant cannot be given, as you all know, that it crosses the placental barrier, and it is known for the teratogenicity. So a very prolonged treatment of anticoagulants and compressions stockings, they are needed in patients with history of venous thromboembolism. Especially, we have talked about the long-term anticoagulation in patients of the heart diseases, especially the mechanical heart valves. So thanks to these two drugs first, the unfractionated heparin and the low molecular weight heparin, which actually, with the help of which actually we sail through these deadly diseases or deadly conditions, I would say, and we can take this pregnancy ahead with a favorable outcome. And thanks to all of you for your patient listening. And once again, I thank the organizers, especially Sir Dr. Muralidhar Pai and our dear friend Dr. Vidya Thobi. I thank all of you, and with this, I just take the opportunity to humbly seek your blessings and wholehearted support for my candidature as Vice President Foxy from West Zone. We have two posts, so in addition to me, you still have one choice for the second vote. I request one of your valuable votes for me. The voting election period is 1st to 10th August. So please do vote, and thank you so much once again.
Thank you, Dr. Sneha. It was a very comprehensive and lucid talk. I just have one comment before I hand over to Dr. Rajashree Paradi for the question and answer session. That, of course, as a general rule, the oral anticoagulants are contraindicated in the first part of pregnancy because of the fear of teratogenicity. But if a patient cannot afford the low molecular weight heparin, after 14 weeks, once the organogenesis is over, we can switch over to oral anticoagulants for two reasons. One is for its convenience. Second one is it's cheaper. And also it is long acting. But that long acting is the problem towards the end of pregnancy. So it can give rise to postpartum hemorrhage. So we have to switch back to the injections around 36 weeks or whenever you are anticipating delivery. And you correctly said, around the time of delivery, we have to again stop it, but restart and continue for 6 more weeks because these patients otherwise will have problems. Fantastic talk, very clear messages and very clear summaries. Thank you. So, Dr. Rajashree, are you there?
Yes, sir, I'm here.
Please continue the question and answer.
Thank you, sir. Thank you, Dr. Kasturi and Dr. Rajashree as well. Thank you so much.
And Dr. Kasturi may finally give her concluding remarks.
If I can ask Dr. Sneha, that it was an excellent presentation and to the point and precise, and having summed up everything right from the risk factors to what are the various indications and how we can suspect the thrombophilias and the occurrence of thrombophilias and how fatal it could be for the life of the mother. Madam, you have done an excellent presentation and summed up very, very well. I hope the postgraduates have logged in and who have greatly benefited from this talk. As rightly put in and pointed by Dr. Muralidhar Rao sir, that one question which I had is whether we could switch to the oral anticoagulants because of the cost factor that many patients may not be able to afford to the injectable anticoagulants, and sir has already clarified it. What is your take on that, madam?
Yes, exactly. In fact, whenever I talk, in fact, this was a very specialized talk on thrombophilias, but when I talk on cardiac issues during pregnancy, I specify that you have to switch over during early pregnancy from warfarin to low molecular weight heparin, and then again at 36 weeks. Maybe you can switch over to warfarin after 14 weeks, definitely. But again, at around 36 weeks, you have to switch back to the unfractionated heparin or low molecular weight heparin. So I fully agree with sir on that point.
And another point, ma'am, whenever we talk of having this low molecular weight and aspirin, and when we need to take the patient for cesarean, there is always this discussion and argument with the anesthesiologist as to how early we should stop and how to convince them, and what are the mandatory investigations we need to do before we take this patient for cesarean once the patient has been on
Yes.
low molecular weight.
Yes, I would answer your question in two ways. Theoretically, at least aspirin, if you see for even for physicians, for any pre-operative fitness, when you ask the physician, they will say at least 72 hours prior you should stop aspirin.
Correct.
And low molecular weight, as you must have heard, I've said that at least 12 to 24 hours. So 1 day prior, if you skip the dose of low molecular weight heparin, that should suffice. Now I talk to you about my practical experience. I have been managing such patients very routinely because I do high-risk obstetrics mainly, and lots of patients with recurrent pregnancy loss, and we find this hereditary thrombophilia, which I have shared few APLA as well. When we are using low molecular weight heparin in such patients, and they, I'm sure like me, many of you are using, but low molecular weight heparin, as I have already said, that doesn't need monitoring even for platelets and the 10A factor. It doesn't have much effect on the major vessels and the coagulation as well. So it is mainly the minor oozing that may just occur. Even if you have the patients presenting it to you in emergency, and the patient has taken or received the low molecular weight heparin injection on the same day, nothing much has happened. That is what our practical experience. Though theoretically, we recommend that at least a day prior we should stop the low molecular weight.
And what investigations would be mandatory in such patients, madam, like to know the coagulation profile of such patients?
For low molecular weight heparin and aspirin, absolutely no, it is not necessary for your safety. You just do a coagulation profile, bleeding time, clotting time, maybe the platelet count and APTT. What we just want to make ourselves safe. For unfractionated heparin, definitely you need to go for the complete coagulation profile, including APTT.
Correct. And there's a question from Dr. Jamuna Kanakaraya. Is thromboprophylaxis mandatory in patients with autoimmune disorder on immunotherapy?
Autoimmune disorders on immunotherapy, if she's like we have already said that autoimmune disorders or certain immunological disorders are considered as high risk for what you call it as thrombophilia. And if this is one of the risk factors, so because she's prone for it, so we consider that thromboprophylaxis is necessary. We score it as 3 if you have seen it. It is one of the high risk thrombophilias.
Correct. Madam, if you could share that risk factor slide and screening slide in the chat box,
Yes,
it would be useful.
I will do that.
Yeah. Because these are the situations wherein, as you rightly said, are life-threatening, and many times we end up maybe getting panicked and getting referred to the high-risk center. But when done wisely and handled with care and with diligence, I'm sure we could do a good job out of this.
Yes. So these are this is the first slide where I have included the pre-existing risk factors. Pre-existing, and here I have mentioned the medical comorbidities like heart disease, malignancy, and certain type of inflammatory conditions like inflammatory polyarthropathy, inflammatory bowel disease, nephrotic syndrome, type 1 diabetes mellitus, nephropathy, sickle cell disease, and current intravenous drug user. So this is the situation which we score it as 3. And that is why definitely thromboprophylaxis is mandatory. And this is the second slide, which is showing the obstetric risk factors. Here I have just mentioned that cesarean section done during labor, that means as an emergency, is scored as high risk, that is 2, whereas the elective cesarean section is scored as 1.
Okay. Another question from Dr. Sonu Batam. What about the effectiveness of unfractionated heparin versus low molecular weight heparin in pregnancy?
I think both of them have their own place. And in fact, what we have discussed, considering the safety, efficacy, and of course the convenience, you usually you have the fixed dosage as per weight. You don't need to titrate the dosage. You don't need to monitor the platelet count and other coagulation factors, and you don't have the risk of sudden hemorrhage or so, even if the patient lands up into emergency. So I think considering these factors, low molecular weight heparin is better. That is what I think. This is what the slide. This is the slide which is saying that which agent is to be preferred.
Preferred. Yes, ma'am. Yes.
Okay. Should I stop sharing?
I think, yeah, there are no more questions there. Thank you so much, ma'am, for clarifying those doubts. And thanks to the Zoom platform and the internet that it has made me possible to log in and listen to your beautiful talk from this beautiful countryside place in UK, as you are able to see. And it's very, very nice to see everyone, more than 70 participants who have logged in to listen to this wonderful talk. Over to you, Dr. Suman Gadi, for the vote of thanks.
Yeah.
I think Dr. Kasturi has to make some report, some concluding remarks. Sorry.
Yeah. Thank you very much, Dr. Sneha. Excellent talk. So much, everything from basics till all the management. And I think after hearing your talk, everybody will be much more confident to handle these cases, because these are the cases where there is little uncertainty whether to give, what to give, and how much to give, and all. So you have made it so very clear. They'll be very confident to this thing. So, and this recording also will be there. Again, will circulate in all our groups, so that those who are missed because of any emergency or those who are in busy, so they can also see. And even our students, some of them are logged in, some are in busy in the labor and all. So I'll ask each one of them to go through this, so they feel very confident to manage such cases. And excellent. And even you made it very clear that when they are on unfractionated, that prophylactic dose, no need of any monitoring. Actually, so that's very patient friendly. But especially our poor patients, we put them on unfractionated, because our government hospital, no, they cannot afford this low molecular weight heparin throughout pregnancy. It is not at all affordable for them. But wherever possible, when we convince the patient, if they are able to take it.
Did we lose the connection? Yeah. Hello.
I think Madam had disconnection.
Yes.
Okay, I think Dr. Suman Gadi, you can conclude by giving vote of thanks. In case Madam gets reconnected, then you can.
Doesn't it?
Yes, she has, yeah.
Okay.
Yes, Dr. Kasturi, I think you need to unmute.
Yeah.
Unmute yourself.
Connection, I think so, in between because of network.
Okay, good. Okay.
Yes.
Only thing we need to, one more thing we need to stress the correct use of this low molecular weight heparin, because I feel sometimes they're overusing it, this low molecular weight heparin, in some cases where actually it's not needed, you know. So we should have clear-cut guidelines when to use, because it is very going to be not cost-effective for patient throughout, and they also have their own side effects, and also especially some people we have seen thrombocytopenia when they are on long-term on this heparin and all. And one more thing, when we put them on anticoagulant drugs, so they need to be consulted regarding the monitoring and long-term follow-up also. So thank you, Sneha. Excellent take-home messages, and a very, very important topic. Nowadays, we are seeing a lot of these cases which were very rare in the past. Thank you so much. Thank you, Muralidhar Pai sir. As always, excellent. You bring the excellent speakers and excellent talk. Whenever this thing is there, we make it a point not to miss it wherever we are. Even from so
Thank you, Dr.
thank you so
Kasturi.
much. Thank you. Thank you, Vidya, Rajeshri, and Suman.
Thank you. Thank you. Thank you.
Yeah, Dr. Suman, over to you.
Yeah, I'll proceed with the vote of thanks. Good evening, one and all. And first of all, I would like to thank the entire team of KCOG, Dr. Hema Divakar, Dean KCOG, Dr. Muralidhar Pai, who is the chairman of KCOG, and also today's convener. And but sir is always a good teacher. Dr. Basara Sajjan, who is vice chairman of KCOG, and Dr. Vidya Bhatt, the secretary of KCOG. I also thank the entire team of Kasoga from our senior patrons, Chief Patron Dr. M.G. Hirimat, Senior Patron Dr. Nagraj, President Kasoga, Dr. Vidya Tobe, Secretary Kasoga, Dr. Rajshri Paredhi, and past President Kasoga, Dr. Kasturi, who is logged in. And of course, today's speaker, Dr. Sneha Budiyar, for Madam's wonderful and informative talk on thrombophilia in pregnancy. It is an important, very important subject because it leads to adverse effect on pregnancy outcome. And Madam has brilliantly detailed everything about it. And thanks all delegates who have joined in. And thanks Mr. Arun for arranging this platform for this webinar. And Dr. Sneha Budiyar, all the very best for your post of Vice President